Next presenter is Dr. Chiappetta. He'll be talking to us about lumbar disc herniations in athletes. Dr. Chiappetta is a spine surgeon and also assistant clinical professor at the Department of Orthopaedic Surgery.
So we're going to talk about lumbar disc herniations, specifically in athletes. Really not going to focus on low back pain or we'll be here for days talking about those kind of things. So I really have nothing to disclose. No one pays me for anything, unfortunately, so we're just common folks like the rest of us. So the clinical question is, in the athletic population, what are the treatment options for patients with a herniated lumbar disc who wish to return to normal physical activity? And then you can stratify that. You can stratify that to the common population, where an athlete, for someone who be getting back to work, getting back to weekend warrior kind of athletics. And the big thing is with athletes is there's a really strict time frame. I mean, sport seasons are 3 months to 6 months at length, so they don't have the time to try physical therapy for 3 months and injections if it's their contract year, or if they're making the playoffs. So their time frame is much different than the average postman or secretary or teacher. So we'll look at some background, the basics of lumbar disc herniation. We'll look at the pertinent anatomy, which I'm sure everyone is very familiar with. The clinical presentation, what do they complain of? How do we diagnose it? Imaging, X-rays, MRIs, and treatment. What do we do once we find them, and how do we get them better? So it's a very common condition in the United States. We treat approximately 200,000 patients per year with surgery. So it's the most common spine procedure that we do. It's usually a very minimally invasive surgery. Most surgeries take less than about 40 minutes or less. Patients generally will go home the same day. So looking at the pertinent anatomy, we have we refer to a lumbar segment as a vertebral body above and below, and a disc in between. So that's the vertebral segment. So with the disc, we look at the axial view of the disc and the sagittal view of the disc. So the key is that the disc has a tough outer angular ring of thick cartilage. The center is the nucleus pulposus, which is a softer material. If you've never seen disc material or touched it, healthy disc has a consistency of something like lobster tail meat. It's soft and spongy, so you can imagine shoving a centimeter of lobster tail meat to someone's spinal canal will cause significant pain. Whereas more degenerative disc, if the disc is pretty worn down and degenerate, it's more like a hard, like pebble almost. So there's different kind of disc herniations. We look at healthy discs, degenerated discs, different kinds. So in the athletic population, young population, we're mostly dealing with a younger, healthy patient with more of a healthier disc, not as much degeneration. So in the center of the spinal canal here, we have our central canal with our thecal sac and nerves running through it. Obviously, the higher we are in the spine, the more nerves there are. At each level, the nerves will exit the spine to different dermatomes and innervate different muscles, and apply sensation to different areas of the lower extremities. So lumbar disc anatomy here is again a cross section. So again, we see the disc space here. Here's your outer annulus, the center nucleus, a rupture through the annulus, and compression of the nerve. Here's an exiting nerve loop. This is the dorsal ganglion of the nerve, central canal, so disc compression of the nerve, which would typically cause your symptoms. In the office, I use the analogy to a jelly donut. Like, what does it mean? How's it happen? Well, typically, the tougher ring on the outside, the annulus will rupture, the jelly will kind of squirt out here, and how much comes out and where it goes can depend upon the majority of symptoms. You kind of get it, especially for the football players. They like pictures. So for anatomy, this is an axial view of the spine. So what you have to keep in mind, perfectly healthy disc is not herniated. Okay? If someone has a perfectly healthy disc like this one, this disc will not herniate. You have to have some weakening of the disc and annulus for it to herniate. So typically you'll see a disc like this or like this herniate. So this one here is somewhat degenerated. You can see how it's sort of darker than this. Anything on MRI that's bright is water. So water content on MRI is bright. So the bright center of the nucleus is the water, a healthy disc. We start losing some here, and here we can see we lose a lot of the brightness. So it's more of like a dried out kind of disc. And here we see a disc kind of herniating into the canal. And so that's why this disc is one that herniates and not this one. So healthy discs do not herniate. Always keep that in mind. So clinical presentation, they usually will start saying, I started out having really bad back pain, and then like later that day or a day or two later, I started getting leg pain. So the back pain is the donor rupturing, because all those nerve fibers in the back lining of the disc, as the jelly squirts out and hits the nerve and the disc herniates, then you start getting the nerve pain or the radiculopathy. They love to call it sciatica. Everyone likes sciatica, so we'll call it sciatica. So it's pain originating in the lumbar spine, radiating and dermatome and pattern down the lower extremity. It's most likely unilateral. Sometimes it'll be bilateral if you have more of a central located disc herniation or a very large disc herniation and they have bilateral leg symptoms. Like over 90% will be one leg versus the other. So they really have paresthesias or numbness, funny feelings going down the leg, microdiscectomy. Of the 14, 5 did not return to competition. 2 of the 5 were football. Two of the ones that did return, 2 had a single level discectomy, 3 had a 2-level open discectomy, and 1 had a percutaneous discectomy, so 1 person had 2 surgeries. Of 9 of the 14 who returned, 1 football player played 3 years at the college level, the rest still played professionally. So Bob Watkins is out in California. He's sort of like the Jim Andrews of back spine surgery for athletes. He and his son now are in Santa Monica. So in 2003, his first study, he had 60 Olympic and pro athletes who had a single-level microdiscectomy. Their surgery criteria were someone who has a documented disc herniation or MRI, they had leg pain playing sport, and they failed 6 weeks of non-op treatment. So as of 60, 53 or 83% returned to the sport at an average of 5.2 months post-operatively. All of his patients had the same protocol. They started physical therapy with trunk stabilization and sport-specific PT average of 3 weeks post-op. So it's a pretty good return. In his study, 83% of Olympic pro athletes returned to their sport less than 6 months after having surgery. And then you look at the subset. So the biggest number, the skewed number, is here football players. So the majority that didn't return, only 75% returned to sport for football, where the rest were all 90% or higher. So all basketball players went back, 19 to 21 baseball players, all the Olympians went back, skiing, swimming, water polo, 100% of hockey players went back, Chris. And so football players have the worst return to sport rate because if you operate on a guy who's 6'4", 320 lineman, you can imagine that those demands on his spine would be a little too much when you get back to sport. So recently, earlier this year, in core clinical orthopedic and related research, in June of this year, there was a nice study put out, again, looking at some of Bob Watkins' patients from the previous study. So they looked at professional, Olympic, and Division I athletes only. And they looked at the specific questions, like what proportion of athletes return to play after lumbar discectomy, and what is effective sport? What is the expected recovery time after lumbar discectomy in elite athletes, and what is the expected career length and performance of elite athletes after lumbar discectomy? And these are all things they're going to ask you. Can I get back to play? So I can't. What's the point? So 75 to 100% of these elite athletes return to play sport. The highest proportion of all the subsets were baseball players. So anywhere between 2.8 to 8.7 months is the average time to return to sport. The quickest ones were the ones with less demanding sports, the longer ones in football. The average career length after a lumbar discectomy ranged from 2.6 to 4.8 years, so not so bad. And elite athletes reached an average of 64 to 103% of preoperative stats after lumbar discectomy prior performance based on sport. So pretty good return. So the sport trials, the spinal outcome research trials, there was a number of them done. These were the landmark studies in spine surgery. They did ones on surgical versus non-operative outcomes for disc herniation, spinal stenosis, spondylolisthesis. So they looked at the disc herniation and how do they do? Well, you have to stratify them out for, does the level of the disc make a difference? L2-3 versus L4-5 versus L5-S1, and it does. The lower the disc herniation, the better the outcome. Short versus long-term outcome. So if you look at patients that had surgery, they had a much better short-term outcome at 1 year, but at 4 years they were pretty equal between operative and non-operative treatment and patient factors, weight, BMI, smoking, workers' comp. So we always say it's a long-term outcome. So there's nothing worse for outcomes than long-term follow-up. So the longer you follow them out, I guess the worse they do. Because what is the fate of the damaged disc? Like we said before, normal discs don't herniate. So that disc, what is the fate of it? They usually will continue to degenerate and have more back pain or possibly a recurrent herniation. Recurrent herniations run between 4% and 8% for the average adult. So there's a less than a 10% chance that this will herniate again. Disc degeneration, once the disc ruptures and is damaged and herniates, it's never the same again. No matter what you call it, it's never the same. Doesn't mean they'll have pain, but they're more susceptible to injury. And need for fusion, because somebody needs a fusion at some point. Well, in elite athletes, that's certainly up in the air. I mean, doing a fusion on 22-year-olds is a pretty drastic thing. They have to have pretty significant findings. So again, Bob Watkins, who we talked about before, did another study. He looked at 171 athletes. Pretty much half had surgery, half didn't. So 85 of those had a microdiscectomy, 86 had non-op treatment. So of those treated with surgery, 89.3% of them returned to sport. These are all elite athletes, Division I, Olympic, or Pro. So almost 90% of patients returned to the sport. So the average time it took was 5.8 months to get back on the field. They have progressive return data for surgically treated patients showed the percentage of athletes who returned were at 50% at 3 months after surgery, 72% at 6 months, 70% at 9 months, and 84% at 12 months. So within a year, 84% were back, and overall 89% were back at average 6 months. So if someone asks you, can I return to what are the odds and percentages? You have a 90% chance, a little bit less than if you're a football player. The key is this though, adolescent discectomies. For those under the age of 17, this is a whole completely different subject because there was a large study done in JBJS, one of our major journals. They had 72 patients, a multi-center study of 16 years and younger had a lumbar discectomy, so a young patient population. They had a 28% revision rate because there's almost a 30% recurrent herniation rate for the young athlete. Why? Well, they're younger, they're probably not as compliant, they have more discs would show to herniate. So for these patients, you have to counsel them. There's a very, very high rate of recurrent herniation, and they should expect maybe it happen. So of the 50 patients that went back to surgery, went back to play. So 50 to 72 went back to play sports. 46 noted occasional or no pain with activity. So here's what endoscopic discectomy kind of looks like. Camera, these come in from more of a far lateral 45-degree kind of approach to the spine. They kind of go outside the spine through the foramen of the spine and try to target this material. I haven't done them yet. I mean, they're more of a fancy marketing tool. In some situations, they may be helpful, but I think most surgeons aren't doing these. You see more pain management doctors trying to masquerade surgeons, trying to market themselves doing these. The jury's out. There's no long-term studies on them yet. So what are complications from a microdiscectomy surgery? So the infection rate is less than 1%. If someone has a disc space infection after surgery, that can be kind of devastating, need long-term antibiotics. The rate of injuring a nerve, people say, well, can I have nerve damage in surgery? It's far under 1%, far under 0.1%, probably under 1,000 little percent. I've never seen a nerve injury before. What happened with a deficit. A dural tear of the lining that covers the nerves can happen 1 to 3% of the time. If that happens, typically you put a stitch in it, and they really have no idea it happens. There's no long-term outcomes. Again, recurrent disc herniations at those levels run between 4% and 8%. Much higher in adolescents. A vascular injury is rare but possibly fatal. There was some somewhat famous actor in the 60s that had surgery and died from having a vascular injury. If you reach too far, hit the aorta. That's not a good outcome. So I think the take-home points is lumbar disc herniations are very common and affect athletes at all levels. Non-operative care can be quite successful. If they're not successful and they can't return to sport, surgery is a very minimally invasive procedure with high success, pain relief. Return to sport is very high, 89%. No, I'll wait for that part. Any questions?
Doc,
Yep.
you hear about these laser procedures. Where do they fit into this whole thing? What are they and what are they trying to do? And
So basically, so you see the commercial. So there is no role for lasers in spine surgery right now. It's more of a marketing tool. No insurance carriers will pay for it. There's no benefits to doing laser procedures. They basically will do a microdiscectomy, and at some point in surgery, say they use a laser. So when we're doing these, Matt and I operate together a lot. We'll joke and say, put the bogey on laser, so we can say we did a laser. But there's really no roles for lasers at all. I mean, if you're going to use a laser and melt the disc, you're going to cause more advanced disc degeneration and probably do more harm in the future than good. And since insurance carriers don't cover the cost of it, they'll typically charge between $10,000 and $30,000 for the cost of laser use. For no extra benefit. There's no long-term studies on it at all. There's not one paper written on laser-assisted spine surgery. All right.